Good morning, good afternoon, and good evening, everyone, and welcome. I see some people are still joining, but we'll get started. My name is Rike Kierkegaard. I work as program specialist with the Health Program Group at UNICEF headquarters in New York, and I'm very pleased to be hosting this webinar with my colleague Lauren Whitehead, who is social policy specialist also at UNICEF HQ. So today we are launching the findings from a new systematic review on bundling economic security and health interventions to reduce HIV and SRH risk among adolescents in Africa. And this was published in BMC Public Health earlier this year. If you could switch the slide, please. So on the screen, you can see the program for today's session. We'll start with a presentation of the findings and a reflection on the implications for programming in the East African context, which will be done by 3 of the co-authors of the paper. And we will then have a quick round of questions and continue with a roundtable discussion where we have 3 panelists that are representing academia, social policy, and the HIV and health perspective. And they will discuss future directions for research and the design and implementation of integrated programming. So before we get started with the program, I'd like to mention a few practical details. First of all, the webinar is being recorded, and the recording and the presentation will be made available on childrenace.org by the end of the week. And then second of all, if you have a question for any of the speakers, please send them at any time using the Q&A box located at the bottom of the Zoom window in the middle, but please do not post questions in the chat box. Please reserve them or reserve the chat box for any general comments or any technical issues. So without further ado, let's get started with the presentations. So to kick us off, I would like to introduce Tia Palermo, who is president at Policy Research Solutions, or PRESTO, and she's former social policy specialist with UNICEF's Office of Research, and she will be presenting together with Kate Rogers, who is senior researcher at Policy Research Solutions. Over to you both.
Thank you. Good morning and good afternoon, everyone. I'm pleased to be presenting findings from our systematic review of bundled interventions targeting adolescents in Africa to reduce HIV risk. I'll be co-presenting with Dr. Kate Rogers of PRESTO, and our co-authors on this work include Rika Kierkegaard, Joyce Wamoyi, Kaylee Grooms, and Shafiq Essagi. Adolescence is a period of rapid biological, social, and developmental change. Threats to the safe transitions to adulthood are influenced by poverty and gender inequality. These often manifest as early pregnancy and marriage, HIV risk, and gender-based violence. In Africa, adolescents also face many threats to educational attainment, and in early adulthood, they face inadequate labor market opportunities. These multidimensional vulnerabilities can in part be addressed through integrated social protection programming. Social protection is defined as the set of policies and programs aimed at preventing or protecting all people against poverty, vulnerability, and social exclusion throughout the life course, with particular emphasis on vulnerable groups. The Global AIDS Strategy currently recognizes social protection as a key programmatic area because it recognizes the role of poverty in impeding progress in achieving prevention, testing, and treatment goals. HIV-sensitive social protection in particular addresses risks, vulnerability, and impact of HIV and AIDS. And while direct impacts of social protection and integrated social protection program on HIV incidence have not been widely evaluated, a recent study compared population data to national coverage rates of cash transfer programs globally. And this study found that increased social protection cash transfer coverage is associated with reduced HIV incidence and increased testing. A lot of intersectoral approaches have the potential to reduce multidimensional poverty and vulnerability. They can also reduce HIV risk and strengthen adolescents' capabilities as they transition to adulthood. These intersectoral approaches are often referred to as cash plus or bundled programs or multifaceted interventions. These bundled programs recognize that poverty shapes vulnerability to HIV risk and also that the economic and reproductive health risks and challenges that adolescents face are closely linked. Most of the pilots that we review today have been implemented by non-governmental actors. However, they mirror how integrated social protection programming can work across sectors, and the findings from this study can inform social protection program development and scale up. Over to Kate.
Thank you, Dr. Palermo, and good morning, good afternoon to everyone. So before we explain too much about our findings, we just want to ground in the conceptual framework that we used for this review. So it was a systematic review of bundled HIV programs, and while our primary outcomes were HIV and STI infection incidence and prevalence, there were a lot of other things that we wanted to make sure we captured. So we assembled a panel of expert advisors to look at various pathways that studies could have picked up that were not necessarily directly examining HIV outcomes. We did this because a lot of those studies don't measure HIV status directly. This is possibly because they don't have large enough sample sizes. There's ethical concerns regarding measuring HIV in social protection programming. So we landed, after much discussion and conversation and going through the literature, on several other pathways that we examined as mediators for these more primary outcomes. And those include HIV and STI knowledge and testing, sexual risk behavior, things including transactional sex, multiple partnered sex, condomless sex, sexual debut, various sexual and reproductive health knowledge, healthy behavior, and then psychosocial and mental health well-being, gender-based violence, experience or understanding, and then gender attitudes, education, and economic security. So this is quite a lot going on in this framework, but that's sort of the drilled down version of what we're looking at. Tia, if you could put the next slide, please. So we had two questions that we asked in this review, the primary being, how do these bundled programs influence HIV outcomes in adolescents and young people? So again, those primary outcomes of HIV and STI incidence and prevalence. And then the second being, how do those bundled programs influence the mediators that I just listed of HIV outcomes in adolescents and young people? And importantly, this concept of a bundled program was not a comprehensive review of all social protection programming, but we did put the parameter on it to have the intervention or the program incorporate at least one health or life skill component and one economic component for adolescents or young people. And we'll kind of unpack that a little bit more in the next slide. So our eligibility criteria was fairly broad. We limited it just to Africa. So nothing specific to above or below the Sahara, just Africa, although the majority of studies returned were from Eastern Africa. Our target population were male and female adolescents and youth, ages 10 to 24. And the program inclusion, as I said, had to have at least one health and life skill component and at least one economic component. So those were broad. Economic is all of the things you see listed here: cash transfers, asset transfers, income generating activities, livelihood trainings, vocational trainings, those kinds of things. And then health and life skills really ran the gamut as well. Health services for adolescents, health information, behavior change communication, sexual and reproductive health education. There were a lot of different pieces that these programs used. And we wanted, again, to capture and cast as wide a net as possible in order to capture as much as we could. We searched programs beginning in 2005 and all the way through 2023. Next slide, please. So overall, what we found, firstly, was that there was a lack of homogeneity across these programs. So what you see here were the most commonly bundled programs. These are not mutually exclusive and they add up to more than what we found. So we found a total of 58 studies that we included in our search. The majority of them had cash and health information, cash and life skills, and cash and mentoring components. Again, they overlapped. So some of these had all of those things. Some of them had none of them, but it was, again, very, very non-homogeneous in terms of what we were looking at. So this was the best way that we could distill down those 58 studies that we looked at. And importantly, what we found was interesting was that although they were not the majority of studies, the studies that included a cash plus another economic empowerment component in addition to the life skills component tended to have the most protective effect. So if it was a cash transfer and fiscal literacy, or a cash transfer and some kind of entrepreneurial training plus the health component, those tended to have more protective outcomes than those that just had a cash plus health on their own. If you could put to the next slide, please. So in terms of those protective effects, the outcomes that we looked at, those mediators that had the most protective effects were economic security. Again, this is, as I just said, was helpful when we saw that it was the combined programming, but also HIV prevention knowledge, sexual and reproductive health knowledge, psychosocial well-being and mental health, and HIV testing. All of those had high protective outcomes. And when we say protective outcomes, it means that it was 50% of the programs or higher had those outcomes protective. And that was either partially protective if they were looking at mixed arms or mixed treatment arms, or fully protective if everyone in the study experienced the protective effect. So those that had fewer than 50% were sexual risk behaviors, gender-based violence, education, HIV incidents. And while we aren't entirely sure why, we've posited that these are harder things to measure, and they also have a lot of gender normative influence and limitations in terms of gender norms and gender-based violence and issues of that nature that possibly limited what the effectiveness of those protective effects were in these outcome categories. Next slide, please. And Tia, I will pass it over to you.
Thanks, Kate. So among the 43 quantitative studies that we reviewed, only 7 of those tested impacts directly on HIV incidence or prevalence. Among those 7 studies, only 2 found protective effects. So one study found that DREAMS programming implemented in South Africa was associated with reduced HIV incidence among girls 15 to 19 years old, while that study found no protective effects in Kenya and also no protective effects in South Africa among females 20 to 24 years old. Another study in Lesotho found that DREAMS implementation was also associated with reduced HIV incidence as measured among females below the age of 26 years who were attending antenatal care. So 5 additional studies evaluated bundled programs and found no protective effects on HIV incidence or prevalence. Next, we turn to other outcomes, which we group across 12 domains, including those that Kate mentioned, such as education, psychosocial outcomes, HIV or SRH, preventive knowledge. So for brevity, we present only what we consider high quality studies on the slides here. And what we mean by high quality studies is referring to the causal identification strategy. So for example, the internal validity of the studies, those that are better able to estimate causal impacts of these interventions. And when we limit only to the high quality studies that were included in the review, we see very similar trends to what Kate presented as the overall findings on the previous slide. So for example, we see consistently that studies are showing protective effects of these bundled interventions on economic security, on mental health, on HIV knowledge, and on sexual and reproductive health, which largely is comprised of sexual and reproductive health knowledge indicators. On the screen here, the circles are protective outcomes and the triangles are adverse effects. Those that are shaded in are consistent across groups or the full treatment arm, whereas those that are shaded or that are not shaded indicate mixed results. So for example, impacts might be protective among a subgroup. So for example, girls ages 15 to 19 years old, but not among those who are 20 to 24 years old, etc. So again, we see very consistent trends across both all quantitative studies evaluated, as well as those that we classified as high quality. When we turn to results by program type, however, we start to see some differences emerge. So we do not present studies on this slide based on all groupings of components. However, we show you a few select ones here. So for example, bundled interventions that combine cash with health information were seen to improve outcomes related to economic security, gender attitudes, psychosocial well-being, gender-based violence, etc. However, these programs were less successful at reducing the risk of HIV incidence, at increasing HIV testing, or delaying sexual debut. In contrast, when we look at livelihoods training plus health information, these interventions were successful at increasing economic security, gender attitudes, and educational outcomes, but they were less successful at improving those outcomes on the right-hand side, including HIV incidence, sexual debut, gender-based violence, etc. Finally, the savings accounts plus cash and fiscal literacy and health information, these interventions were successful at improving economic security, sexual risk behavior, HIV prevention knowledge, and mental health and psychosocial well-being, but were less successful at improving gender attitudes, education, sexual debut, and gender-based violence. So what these findings tell us overall is that despite marginal improvements in economic security, so people might be more likely to be employed or engaged in livelihoods or have increased consumption, these economic outcomes are improved. However, it's likely that participants remain poor and that most interventions likely only addressed economic strengthening at the adolescent level. This means that households in which the adolescents and young people live often remain poor or food insecure. And therefore, programming in order to affect more change on other outcomes might need to address household level economic security. So for example, this is the aim of many social protection programs. In addition, because we see that a lot of these relational outcomes are not significant. So for example, we see that programs were less successful in improving outcomes that were either more distal outcomes or were somewhat relational. So what we mean by that is sexual behaviors, gender-based violence, things like that are not only determined at the adolescent level, rather they're determined at the couple level or the community level, and therefore community gender norms might need to be intervened with in order to see broader improvements on outcomes related to health, education, and other of these sexual risk behaviors. So for example, some of this integrated programming can also be implemented through these other sectors. So they can be linked between social protection programs or similar interventions to what we reviewed. So these linkages, what they might look like in practice, include referrals to either health services, livelihoods intervention, extension services. They can also mean health insurance premium fee waivers. So for example, households participating in social protection programs can be linked to national health insurance schemes or community-based health insurance, and the financial barriers to having them participate in those programs can be mitigated through the provision of premium fee waivers. And we've seen examples of this recently in a few countries. And I'm going to turn it over to Kate. Thank you.
Thanks, Tia. So overall, the conclusions were that interventions were most effective at improving economic security, HIV prevention knowledge, sexual and reproductive health knowledge and behavior seeking, mental health, and psychosocial outcomes. They were less effective at affecting HIV and STI incidence, sexual risk behavior, gender attitudes, and sexual debut. So what we've determined from that is, I deleted my notes as I'm talking, my apologies, is that these programs also did not appear to benefit the boys and girls that were part of the interventions in the same way, and that they can improve adolescent health and well-being, but the program design and the implementation characteristics and the cultural context are very important for their success. So while some of these are designed to be very broad-ranging, it's also important to look at what's happening on the ground in the places they're being implemented for them to be as successful as possible. And as we said before, heterogeneity across programs and outcomes made it difficult to draw sweeping conclusions. The standardized measures to compare combinations would be really beneficial in this aspect, and the implementation research to help understand the successes and the challenges, again, across those various contexts where programs are being implemented would also be helpful to better understand best practices. And pretty much having some kind of complexity balanced with the scalability. So when we're designing new programs, striking that balance between standalone programs and programs that can be scaled will be important, again, in understanding how things look when they're actually implemented on the ground. And that is all from us. I think there's one more slide, but it's just a thank you slide. And then we'll pass it on to introduce one of our co-authors, Joyce Famoi, who is a social and behavioral researcher at the National Institute for Medical Research in Tanzania, who specializes in understanding social and behavioral determinants of adolescents and young people's sexual and reproductive health and structural drivers of HIV. So Joyce, we will turn it over to you.
Yeah, so thanks very much, Kat. Mine is just to quickly reflect on what these findings might actually mean, specifically for programming, and I'll try and do that in about 3 to 5 minutes. So we've actually seen positive results in some of the programs. We've seen some impact, especially on what I always call the easy reported behaviors. But clearly we see the problem of HIV incidence remains a major issue. And I think that's one of the reasons that we program for girls, so that we can reduce issues related to sexual and reproductive health, in particular HIV and STIs. So I think there is hope actually in this bundled intervention, but clearly to just think through what is that you're bundling with, and maybe to explore even a bit more. Does some of this bundling actually in fact reduce the effect or the significance of some of this intervention? So just moving deeper to understand what the bundling and how, what aspect of the interventions that are combined is actually having an impact on a particular group versus the other. So more research is actually needed on that, but also just we see that structural barriers are still a huge issue in this setting, in as much as the social protection interventions are doing something, barriers are still massive. And I clearly agree with the conclusion that has just been given there related to these social protection interventions targeting families and the broader context of the adolescents rather than the adolescents themselves. We have lots of issues at play in the lives of these adolescents, and we know that they're not as powerful in terms of decision making and overcoming these norms in the way that we imagine they would through the individual focused interventions. So really targeting family level would really help. And I know it's easy said like this than really when you put it in a program, because if you have a program that targets economic vulnerability of families, clearly you're talking about a huge program here. But it seems like that's what it is, really tackling the structural aspects, economic vulnerability of families and just the adolescents. And we've seen efforts, for example, through programs like TASAF that have also again shown mixed results. This is the Tanzania Social Action Fund. Some have actually also some aspects of some variables have been positive, but we increasingly see that there's still something lacking there. And that actually leads me to recommend that probably continued working with government structures in terms of really taking some of the bits or some of the bundled interventions that have worked is really important to have them at scale. And what Kate, you recommended towards the end, this is going to be interministerial, clearly. And when we start talking about that, as much as it's a good term, it's really difficult to coordinate some of these programs at that level. The funds we are talking about here to run social protection programs in countries like such as Tanzania are all donor funds again. World Bank has been on the forefront actually funding these programs, for example, in Tanzania. So we talk about even thinking about some of the elements, some of the programs that have worked to scale, and then we just think about funds. So it's good that we're actually walking this journey to just see what is working and clearly how we can really get that replicated in other areas, but thinking about how we can have governments having strong systems, strong policies that they can actually help with scaling up of some of these bundled interventions. But our key one, just before I finish, is the issue of tackling harmful gender norms. We have seen that the interventions, the different bundles actually struggle to impact relational factors. And relational factors are really key. If you're talking about relationships, you're talking about sexual health, reproductive health, clearly those have to be tackled. And when you tackle one person with the adolescent girl, for example, for adolescents themselves, then clearly you're forgetting about other factors. And we've seen interventions try, but we think lots needs to be done in terms of working through community sort of massive programs. And again, easily said than done, because program that engages community leaders, parenting is already underway. Those are not small programs. They're programs that need good funding, but it's just good for us to be aware that probably that's the way we should be thinking. And another possible way, of course, to shift some of these social and gender norms that are really making some of these programs struggle is the use of bundle some of this with what I call mass media interventions, because those are the ones that can easily tackle harmful social norms at a sort of a community level. But again, so those are just things to think through, not easily done, but it seems like we have to really be aware when you're talking about bundling. What is that we are bundling? For what context, for what population, with what resources, what can be scaled up, and what is that can just be done as a standalone little thing that makes a little impact as well. So those were just some of my quick reflections. Back to you, Kate.
Thank you so much, Joyce. This was really a wealth of information, and I'm really glad that you mentioned the issue of how to take these smaller demonstration models or pilots to scale, and how can we make them work interministerially, because I know that that is something that our panelists in the roundtable discussion will also be talking about. So hopefully we can unpack that a little bit more. So let's move on to that. With us, we have three panelists. We have Lucy Kluber, who is Professor of Child and Family Social Work at Oxford University and lecturer in Psychiatry and Mental Health at the University of Cape Town. We have Paul Crossman-Ufford, who is UNICEF's Regional Advisor for Social Policy in Western Central Africa. And he's also worked in the East African region as Chief Social Policy with UNICEF in Tanzania, Zambia, and then also in Vietnam and Senegal previously. And then finally, we have Kokeka Nokoduka, who is currently HIV and Pandemics Advisor with UNAIDS's Global Center based in South Africa. And she has previously served in various capacities with the government of South Africa, including as Executive Manager for implementation of the National Strategic Plan at the South African National AIDS Council. So we will have around 5 minutes for each question. And Lucy, let's start with you. How do findings from this review contribute to what we already know about designing better programs to reduce HIV risk among adolescents and improve the overall well-being? And where do you think the field should go next in terms of research?
Well, thank you, Ricky. And I've got congratulations and then 5 points to make. The congratulations is to Tia and Joyce and Kate and the whole team, because you know, a systematic review is normally asking a question like, does aspirin prevent heart attacks? And that means that it is a nice, simple input and a single outcome. And what we have instead here is an extraordinarily complex set of inputs and an extraordinarily complex set of mediators and outcomes. So just a huge, huge congratulations for this incredible amount of not just work, but also thought that has gone into this. So my first point is that it made me think about the development of other components and other types of HIV prevention. If we look at something like PrEP or antiretroviral medication, there were years and years of trying out different combinations of medical, of kind of biomedical components of those interventions, different combinations in different levels, for example. And I think that what we're at is somewhere in the middle of that research process. It's saying that we are seeing these positive effects of these multi-sectoral, exciting interventions, but that we're still trying to understand exactly what are the right combinations, in what, to what extent, and in what context. And I think that that's an exciting and important place to be. I think someone might have their sound on, so if they could switch it off, that would be great. The second point is that I was really struck, both reading the review and also listening, in thinking that we need to consider both the prevention group, but also those young people and adolescents who've already become infected. And I think what was really encouraging was that we were seeing positive results of interventions, of multi-sectoral interventions or bundled interventions that are very similar to the things which are improving outcomes for adolescents living with HIV. And UNICEF Asaro has done some excellent work on that. But you'll see very similar recommendations in terms of economic support combined with psychosocial and other types of support. So I think that's a real positive for this field. The third thing is that we need to move forward in thinking and understanding about what is most scalable. We're developing an understanding of the best combinations, but the one key next stage is to move forward and say, how are we going to be able to deliver those at a population level? How will we be able to identify innovative ways of delivering programs to entire populations of children and adolescents? And I don't think we're there yet, but I think there's exciting new work when we think about hybrid digital delivery, combination deliveries that can drive down costs, especially in this kind of new context of challenges to aid funding. The fourth point is that I do think that with a focus on HIV, we may be underestimating the impacts of some of these programs. And I think cash transfers is a primary example here. If we look at cash transfers and the evidence of impacts on adolescents, we see a massive range of impacts, from education, from staying in school, to delayed debut, to long-term impacts on life opportunities, labor market productivity, for example. And so when we think about the programs that we are highlighting and prioritizing in HIV prevention, we may also want to think about what are they doing for other outcomes, mental health, physical health, reduction of crime on a major scale. And to think about how we talk to governments and agencies with not only single narrowed outcomes that are of great interest to us in the HIV field, but also thinking about which interventions can bring great bang for buck for a government that has a whole set of things that they are worried about. Now, my last and fifth point is to say what's next? What are some of the things that we need to look towards over the next 5 to 10 years? And I think we've, Tia and Kate and Joyce have already highlighted important ones, but I would add two. The first, that we really need to start thinking about prevention in the context of some of the great challenges that are going to be facing Africa's adolescents. And those two that really jump out are the next epidemic or pandemic that we may not be able to predict, but that WHO predicts will be happening in our generation. And the climate challenges and crises and severe climate hazards that these young people are facing. And so we are making great progress in this research. We are finding effective bundled interventions, but we have a whole set of work still to do. Thanks, colleagues, and thank you for a fantastic review.
Thanks so much, Lucy, and thank you for bringing up some of these really important issues we have to think about, both in terms of some of the research and especially implementation research that we really need to understand in terms of what we can scale, how do we scale it, how do we go from pilots to population level, and especially like your comment about underestimating the impacts of these interventions by only looking at HIV. I mean, with this paper, we really tried to cast a broader net, looking at various outcomes, recognizing that if we're tackling structural drivers of HIV, we will be tackling drivers of other outcomes as well. So with that, I'll hand over to Lauren.
Great. Thank you so much. I'm really glad to be here, everyone. As Ricky mentioned at the beginning of the call, I'm Lauren Whitehead. I'm on the social policy and social protection team at UNICEF. And I am going to pose this question now to Paul, who is our regional advisor for social policy in the West and Central Africa region. So Paul, from your experience, especially some of the experience that Ricky highlighted earlier, including your time in Tanzania, what does it take to deliver on these types of integrated multi-sectoral programs at scale, specifically with government partners? And what do you think some of these findings mean today in the context of national social protection systems and some of that multi-sectoral coordination between social protection and other sectors?
Yeah, thank you, Lauren. And good day, everybody. And really feeling privileged to talk on this panel and joining Lucy in big congratulations for the fantastic review and the compelling evidence that you put together on the bundled interventions. Fascinating and lots of potential. I was thinking cash transfers are actually a relatively recent intervention, especially in Africa. It's maybe about 15 years or so that these programs have come to scale in many countries, and bundled approaches using cash transfers as a platform are even more recent in terms of being designed and being tested and rolled out. At the same time, cash transfers, in my view, have been among the most scrutinized policy interventions, maybe ever, among sets of social policies. So we have a wealth of evidence, but we are faced with a contradiction. Despite the wealth of evidence we have on the impact of social protection programs in general, and cash transfer programs in particular, in many countries in sub-Saharan Africa, we are still seeing that these programs are rolled out at a relatively low scale. Of course, with a couple of exceptions, but in particular in this region, West and Central Africa, and also in other parts of the continent, low scale. So how do we explain that? And it puts us in front of the question, so how can we bring these programs to scale because we have such a wealth of evidence? I think we need to think about scale in two ways. First, we need to think about scale in terms of the routine national cash transfer programs. And secondly, about the bundled interventions that we build on that. And the routine, regular national programs need to be there at scale because that is the platform that we use to build on with other interventions, whether these are complementary services, information, referrals, capacity interventions, but they build on the foundational program of a national cash transfer. So we need to think about scale there first, and then scale and delivery for bundled interventions. So the question also is, why are these programs then not yet at scale? Why are they not prioritized by countries to put their finance into those programs, despite what we know about the evidence and despite what we know about their affordability? Programs at scale, 20–30% of the population, do not cost much. And they have a really, instrumental impact on facilitating access to services on a range of outcomes. Lucy mentioned that already. And of course, that is related to some political decisions made by policymakers in the political economy. Other competing priorities, prevailing perceptions around affordability of these programs, prevailing perceptions about what these programs do. And we all know the myths about dependency, sustainability, etc. So why are we on the one hand, with a fantastic set of evidence, and on the other hand, these issues in the political economy. And there is a lot to learn and a big agenda for UNICEF and for other partners to engage more strongly and effectively in policy dialogues with the evidence that we have. And one of the lessons that we learned is, in terms of impact evaluations, to work with actors in the national social protection system right from the start. And I cannot emphasize that enough, to have people understand the conceptual framework, Kate, that you presented, to have them understand the range of impacts that we are finding, to have them understand some of the limitations and the way the design of interventions can help overcome that. So that is important learning that we have, and that we need to more effectively engage with policymakers to have them prioritize those interventions. And in the first place, as political statements, they need to be prioritized in policies. And it's not only the social protection policies. I've seen many sort of health programs, national health strategies, health policies, youth policies, adolescent action plans, where social protection programs have been only just referred to in a very limited way and not at the core of these programs. So there is a way to engage in a policy dialogue, not only in social protection, but in the other areas as well. So that's more about the policy side. Now, when we come to the bundled interventions, and in UNICEF, sometimes we use the cash plus term, to say we have a cash program and then we implement a plus component. So how can we bring that to scale? So a few points there. I think there's a lot has been said around program design. I think, Lucy, you referred also to making these programs not too complex, and start with relatively simple bundled interventions based on what we know that works in this particular context as a starting point. But inevitably, at some point, we need to think about delivery. And what we have seen from the presentations is bundled interventions require significant capacity to implement. A simple cash transfer is relatively straightforward, including with the digital means we have nowadays. But the bundled intervention, a life skills training, information sessions, referrals, coaching, etc. So who is going to do that at scale? And we have a lot of experience on how to do that in projects, but we have little experience to do that through the system. For instance, through the social service workforce. And I've come back to that in many discussions. Investing in the social service workforce, those people in the front line of service delivery, whether it's a social worker, a community health worker, other welfare assistance committee at the local level, we need to invest in that workforce to be able to take on some of these tasks. And in context where that is not possible, we need to think about other delivery models. For instance, I have always saying that it is important that the foundation, the cash transfer program, is implemented by the government and under government oversight and guidance. That is very critical. With plus components, when we face limited capacity, we can think of other models where non-governmental organizations or community-based organizations work under that program to contribute with implementing the bundled interventions. And in other contexts, we have called that a twin track approach. Government with the coordination and oversight, other organizations helping to implement a government program where capacity or access is lacking. And that government coordination is very critical because we have seen too many sort of siloed projects of bundled interventions that were disconnected from mainstream government programs and government workforces. So maybe that is something we can discuss further today. And these were the points I wanted to raise to start with. Lauren, back to you.
Amazing. Thank you so much, Paul. I think there were quite a few things that you said that really resonated with me, and I think are also echoing back some of what we heard earlier. That last point, especially around the delivery challenges on the bundled interventions, and recognizing that, there's not necessarily going to be a situation where government can do every single additional plus component to the level that it needs to be done, to the level it needs to be delivered. So we really have to think about how we're engaging other actors. And that's also part of considering a multi-sectoral approach, is kind of a multi-stakeholder approach to delivering on some of these. I think I also heard really clearly from you talking about the need for a core foundation, a systems strengthened foundation for cash transfers within the national system to build on. And in many cases, despite the evidence, we don't even have that foundation in place. And so in some ways, we're asking a lot of a system that is in a fragile state of its own, in many cases where those are not very well rooted. And so we really need to invest in national ownership and leadership and delivery of that core foundation of the cash transfers. However, we're up against the 3 Ps, if I can summarize it that way: the political economy, the priorities which are competing within government, and perceptions as well when it comes to cash transfers, and that myth of dependency and that myth of whether or not we're going to be able to sustain this because people are going to be relying on this long term. So there's a little bit of that work that needs to be done in the context of thinking about these bundled interventions, while also considering that government can't necessarily do all in some cases and might need some additional support for delivery of those bundled interventions. But still very promising, and I think very timely to think about some of these things with this research coming out and the fact that there's a proliferation of bundled interventions that will continue and continue to grow in this way. And so I will go ahead and pass it over to Rike now for the last question for the panel, and then we'll be able to open up to questions and answers for everyone here.
Thank you so much, Lauren, and thank you, Paul. And this is a very good transition to Kokeka, because Kokeka, you have been on the other side of this equation, trying to work across sectors, HIV, health, education. So very curious to hear your perspective on this. So from your experience, how can we strengthen intersectoral linkages, and how can we facilitate buy-in from respected sectors like health to work together with social protection systems and vice versa, to maximize impacts among adolescents? And what are some examples of these linkages being operationalized?
Thank you very much, Rike, and good afternoon, good morning, and good evening. And congratulations to the team on the release of this research. And I think really it's coming at the right time as we are trying to make sure that the interventions that we are implementing are contributing towards meeting the SDG goals. And 2030 is around the corner. Therefore, we need to be able to showcase that the interventions that we are implementing are interventions that are going to give us results. So in terms of collaborations, I think we all agree, and the research also proves that the multisectoral and multidisciplinary combination of social protection interventions will be interventions that will give us the necessary outputs that we require. We have seen in South Africa, I think South Africa is one of the best countries in terms of social policy in the sub-Saharan region. I think the different government departments, as well as the different sectors, have developed social protection interventions that we have been implementing in the post-apartheid era. But I think the biggest challenge that we have is to bring all these social protection interventions together to show effect of bundled interventions. And I think one of the key challenges that I've noted with the work that I've been doing across the different sectors, but also working at an institution, which is the South African National AIDS Council, that was responsible for providing coordination of the different sector implementation, is the fact that different departments or different sectors have priorities based on their own mandates. And each sector then drives its own priority without looking at what the other department is doing. But if you look at where the social policy of South Africa is, you look at the Department of Health, there are specific social protection interventions. Specifically, if you look at the gender lens, adolescent girls and young women, we look at our social development department, which is a department that is responsible for implementing the social grants and other social interventions, and also looking at the education sector department, which also provides social protection within the education sector. But I think the challenge is to bring everybody together. So I think for me, the recommendations that I would like to table here today, few, is that we need to inculcate a culture of joint planning and shared goals. So I think at a political level, we can drive the agenda around shared goals, and at a policy level and implementation level to say, how do we focus on ensuring that there is joint planning so that all our social protection interventions can be bundled and can target the same vulnerable individuals that we need to work with. We need to use combined or harmonized databases. For example, in South Africa, a vulnerable girl will be accessing a child protection grant. They will go to a non-fee paying school that will make sure that they have access to scholar transport. They have access to a meal when they are at school. And some will then have material support like your uniform and other material support. And we've got other interventions from the Department of Health, from the different partners that we are working with. But currently, as I'm sitting here, we do not have a system that is able to track the same girl across the different interventions that are across the multi-sectoral provision of the services that they will require. So I think harmonized combined databases can then assist that we can then be able to track the impact in terms of reducing vulnerabilities and addressing the dimensions of vulnerability to each of the individuals by making sure that we can be able to track. The last one for me, I think we have to train our service providers across the different sectors of social protection so that we can then be able to ensure that our workforce is skilled to be able to identify other vulnerabilities that they are unable to provide services for and be able to refer the adolescent girls to other services and be able to track and have conversations and communications around that harmonized implementation and harmonized tracking of the services. I think I agree with the outcomes of this research that cash alone, cash transfers alone would not be able to address the vulnerabilities, but we need the plus. And for us to get to the plus, we need a multi-sectoral and multidisciplinary approach to delivering these services. And we also need to make sure that as we provide bundled interventions that are led by government and are led by agencies, but we also pull with us communities, especially caregivers and parents, to be part of the interventions that we will be providing so that parents can play their role in supporting, in addressing, but also the interventions should include to make sure that parents got access to training and support for parenting skills, but also support and training for some of the management of the interventions that they would receive. I'll stop there, okay, thanks.
Thank you so much. Yes, that was very interesting. And what really struck me was what Paul was saying as well, is that to get to the plus, we really need to think about the foundation first, have a comprehensive data system that can track a girl or adolescent across sectors, across different interventions, make sure that we do appropriate capacity building so we're actually able to implement these multi-sectoral approaches. And we think about that it's not just targeting an intervention to an adolescent, but that adolescent is embedded in an environment. So how do we incorporate that environment, the caregivers and the communities around? So a lot of food for thoughts. So on that note, let's move into the Q&A. And I will admit that I got so eager after Joyce's presentation that was really neatly leading into the Q&A that I forgot to do the first Q&A. So I'll hand over to Lauren, but we will jump back and look at a few of those questions for the first presentation. Some of them were answered in writing, but they are worthwhile picking up again. So we'll have around 15, 20 minutes. So over to you, Lauren.
Great. And I also agree with Rike. I think the earlier presentations were really great. And so we just sort of plowed ahead. But thankfully, I think we've had quite a few questions that were answered in the chat. There is one new question that we'll pose and then maybe allow for a voiceover of some of the other questions that I think others on the call may also have as well. So one of the questions that's unanswered right now is from Edward. Did we evaluate the underlying causes of the need for social protection in the first place? And did any of these determinants have an impact on the effectiveness of bundled intervention? So thinking about some of the underlying characteristics, for example, of households and adolescents as some of the underlying causes that might have put them in a position to need some support from social protection to start with. And then would multi-sectoral interventions that also improve the overall socioeconomic transformation of communities be more impactful than focusing on a limited demographic? And by this, I think he means adolescents specifically. So it's two pieces of that question. Did we evaluate the underlying causes? And then also, would multi-sectoral interventions that improve socioeconomic transformation be more impactful than focusing on a limited demographic? So maybe if we start with that question, and then I noted that I think, Tia, you responded to a question also from Suzanne around whether or not you could define what you included in your definition of sexual and reproductive health that falls under the areas with positive effects. So if you wanted to just voice over that a little bit more clearly in terms of what you were considering as part of sexual and reproductive health, I think that would be beneficial to the full group. Thanks. And that first question is open to anyone who would like to answer around whether or not we evaluated the underlying causes of the need and multi-sectoral interventions that benefit socioeconomic development as a whole.
Maybe I can answer those backwards. So Suzanne, yes, thank you for your question. It's a good point. We probably could have done a better job at naming this dimension, but what we were including in these outcomes include knowledge around sexual and reproductive health, knowledge of modern contraceptive knowledge, also use of contraception, knowledge about fertility cycle, where to seek sexual and reproductive health services, and whether people sought services for sexual and reproductive health or biomedical services. In terms of the open question, so most of the studies, they did not test moderating effects. So for example, impacts among groups that were perhaps out of school versus in school, or, impacts in communities where health services were of higher quality and more accessible, et cetera. So we really didn't see a lot of tests of moderators, but I think a lot of the interventions were informed by, a deep understanding of the context. So for example, some of the DREAMS intervention components were targeted specifically to out-of-school girls, or programs were targeted based on different vulnerabilities in those contexts. So it's a little bit hard to generalize across all 50+ studies on how that was done, but I would say that that's a pretty large gap, trying to understand how these contextual factors moderate. And I think some of the contextual factors that are really interesting to test would be like community level gender norms and gender attitudes, or quality and accessibility of health services. So I can give an example from a cash transfer impact evaluation. It was a Cash Plus program, which provided cash transfers in Ghana combined with fee waivers for cash transfer households to enroll in health insurance. And what we found in that context, and this is how all households, not just adolescents, but it goes to the point of moderating factors. What we found in that context is that the cash plus fee waiver increased the likelihood that people would enroll in health insurance. And so theoretically, that improves their access to health insurance. But interestingly, what we found is that the program had much larger impacts on health insurance enrollment in communities where health facilities were found to have better quality services. And so it suggests that people are making their decision on whether to enroll based on what benefit they think they're going to get from enrolling in those services. So that's an example of a study that has looked at moderating impacts, but among the bundled interventions that we reviewed, the studies were not really able to do that, and rather estimated impacts among the full study group. Over.
I think back to you, Rika, for additional questions that we have from the chat.
Yes, thank you. We had a question around HIV incidence, and Kate, I saw you answering that. So we have actually two questions for you. One is around if you could give more details on the approaches that did not have any effects on HIV incidence. And I'm wondering if I can just throw in a follow-up question, if you can also just talk a little bit about the whole issue with measuring HIV incidence, or at least how not many studies specifically look at that, but look at more proxy outcomes. And then there was another question around costing. If you look at the cost of these interventions, because cost effectiveness would be important, we're looking at scaling up the most promising interventions.
I can start, and then if anyone wants to jump in, costing is definitely not my wheelhouse. So, but I will say that was outside the scope of this review. There was a lot to tackle here as it was. So we did not include any papers that discussed costing. We did talk about it as something that should be done for the future. So I think that would be really interesting, again, particularly when we're looking at scalability and what's viable. And that kind of leads us into a lot of the HIV incidence and prevalence outcomes. They were the majority of what measured HIV prevalence and incidence were DREAM studies. And because of the way, and Tia, feel free to jump in here at any point, but because of the way that they were described in a lot of the papers, it was difficult to understand which components were being implemented in which setting. So we had a lot of DREAMS papers. There's a ton going on with that program that's very incredible and doing really good work, but it was hard for us to know which components of which programs were being implemented. So often the papers that use DREAMS data just said DREAMS implemented in X country. And so what we found, again, there was 7 studies that looked at HIV incidence. The majority of them, I think 6 were DREAMS and 1 was SAS maybe. And only 1 found fully protective effects. And that was for adolescent girls. I think they were 13 and 14 years old. So again, it was difficult to know which components were being implemented, but mentorship seemed to have some kind of correlation to it when we looked at those programs that included discussion about mentorship. And there was a component of gender, which again, I don't want to overlay that, but it seemed like adolescent girls were more often seeking HIV testing and services than adolescent boys. So I don't know if that really answers the question. I don't know, Tia, if you want to add anything to that. But, oh, sorry, the last piece of that being what those issues are with actually doing HIV testing. I think, again, like those ethical concerns about doing HIV testing or just simply from a sample size standpoint. But again, that's where those mediators tended to be more helpful in looking at things like condomless sex or transactional sex and things like that as proxies.
Thank you. I see some raised hands. Paul, please go ahead.
Yeah, maybe just a few reflections on what did not work. I've seen in my experience things that not work that I would qualify not as cash plus, but as plus cash. And that is multi-sector programs where cash transfers have been just an add-on for a limited duration. And I think, it's very important to go back to what the evidence shows. And the best impacts come from programs that provide regular and predictable cash transfers over a sustained period of time. We know that we don't see the same level of impacts if it is just a couple of payments, because people take different decisions in terms of how to use those funds that come to the household. So I think that's an important aspect. Another thing that I wanted to bring to the table of what doesn't work, I've seen several projects in where the cash transfers were provided to adolescent girls directly. And we often overlook the risks that come with providing such vulnerable girls with what can be a substantial amount of money in their community. The logic of a cash transfer program, in my view, is that it alleviates constraints at the household, and that has positive impacts on outcomes for children and adolescents. But in essence, it is a household cash transfer. But of course, we cannot overlook the fact that we have many households that are led by adolescents and adolescent girls. That's a fact in many countries in which we work. And I think that requires very tailored approaches to assist those type of demographies, those households, to overcome their constraints, ideally with the assistance of a social worker or another type of community worker, given the specific vulnerabilities. Over.
Very, very good point. Very good point to keep in mind. Also remembering the safeguarding aspect. Lucy, may I, not to put you on the spot, I just remember we've also had conversations around costing, and I was wondering if you have any comment on that.
I think that we have, as researchers, not taken seriously enough the real need to think about bang for buck. And I think that we can do better in how we do that. We've recently been working with colleagues at UNICEF, at Asaro, at HQ, in the Kenya office, in developing an economic model of the impacts of a cash plus bundle combination for adolescent girls. And it's been incredibly interesting to see how we have probably underestimated massively the bang for buck that we can see for these bundled interventions. Perhaps if I can show for one moment, I may or may not be able to share, but it could help us to just realize how much of an impact we can see. This was developed on 3 interventions, not necessarily the best 3 that could have possibly been done, but the evidence suggested that these were all highly impactful accelerator or multi-sectoral interventions. And we found that the combination of cash transfer, adolescent-friendly SRHR services, that was training healthcare providers, and an evidence-based parenting program resulted in this set of extraordinary outcomes. This was based on around 340 randomized trials, which we used the effect sizes of and built an economic model. And we can see that not only is it resulting in these HIV outcomes and HIV-related outcomes, which are of real importance to us, reductions in adolescent pregnancies, HIV infections, cases of sexual violence, but we can see this massive return in labor market productivity, so 4-to-1 return. Now, is that the full answer? No. But what I think it is starting to tell us is that we can start thinking about and advocating for economic support for social protection and bundled interventions in ways that are going to speak to the needs of governments. You know, Paul, as you were saying, you know, the cynical government who's saying, can we really afford to do this on a sustainable level? Well, when it's producing a 4-to-1 benefit on labor market productivity, the answer may be somewhat closer to yes.
Yes, you can. All right, Lauren, over to you for the next questions. Thank you so much, Lucy.
Great. No, really, thank you for that, Lucy, and also Paul as well. And thank you, Lucy, for having something on the fly to actually be able to share with the group. I think that's actually really demonstrative of some of the impacts that we're talking about, and also really indicative of different ways that we might need to position some of this argument for certain groups that we're working with, where we see that there's a significant evidence base, for example, around adolescents. So I have one question to pose towards Paul, and then I think there's a hand that was raised as well in the room, I believe Junior. So we'll come to Junior next. The question for you, Paul, is more around thinking about these issues that we face with scale for some of these foundational elements of social protection like cash transfer programs, and how we reconcile that a bit with more of a life course approach, which inherently targets certain areas of interventions towards certain demographics and groups. How do we consider that at scale? How do we consider encouraging government to take on some of these types of interventions along a life course perspective, recognizing that there are different needs for different populations at certain times, while also balancing that with the need to scale and not have these very, very small scale interventions for very, very niche specific groups? I hope that makes sense, but let me know if not. And then we'll move to the question from Junior next, if he's still here.
Yeah. It's not an easy question. Thank you. I think Lucy was alluding to that also with the case on the head to making the investment case. We should not just sell to governments the very specific outcomes, for instance, we see for adolescents, but to make the case for prioritizing use of domestic resources for social protection, we should also evoke the local economic development impacts, the broader community impacts that we see, the investment case for the economy. We need to become a bit more powerful at that. And the Kenya example is fantastic, really. And then, of course, the advice is to have relatively simple social protection programs at scale. And from the UN side, the advice is indeed a life cycle approach to address vulnerabilities for children, working age population, and the elderly through different instruments, including, but not limited to, cash transfers. Right. And we have such a foundational, simple program. I think countries like South Africa, perhaps also Kenya, are relatively good examples of that. We can find in those families more targeted groups. I think Tanzania is also an interesting example. There's a program relatively at scale. It reaches 1 million households. In Tanzania, that is still only about 10% of the population, but 1 million families. And that was used as a platform to reach the adolescent girls in those families. So not starting with that demography, but at the basis of a broader program. And I think it is an important argument also that these programs that target more widely tend to get broader political and societal support than more targeted programs. And of course, a very critical argument is that they are better at avoiding exclusion. And it's always frustrating to see that highly targeted programs, difficult to implement, you easily create exclusion in communities where vulnerability is widespread. So using the investment case for broad, categorically targeted programs, and within that finding bundled interventions for specific subgroups. Something along those lines.
Thank you so much, Paul. And sorry, I just realized my mic was on the entire time, so you probably heard me nodding and agreeing, murmuring consent, just because I do think that is a very, very important point to make, this idea that, again, we need this foundational approach across the entire life course, but that benefits the entire household. And to Lucy's point before, that's part of where the investment case comes in, this overall economic development, what we're able to see when we're lifting all households that need this area of support, and kind of these categorical ways of being able to target intervention so that it does still have the demographic impact on certain populations, as well as specific bundled interventions that are necessary for certain populations. So I think points very well taken, Paul. And I see that Junior's hand has been lowered, but we do have a new question, which is from Alexander, and it says, could we extract indeed from the review some other interventions that didn't have any effects that we might not consider going forward in bundled interventions? So were there any particular interventions that stood out to the researchers that were particularly not impactful, insignificant, and therefore should not be considered going forward, or perhaps with some caveats, as is usually the case?
So maybe I can take that, and I'll just answer perhaps a bit generically that, echoing what Paul said, it's really important. So these drivers are at structural, community, and household levels, these drivers of vulnerability. And so the solutions to these problems are going to be at all of those levels. We need the policies across sectors, including social protection, health, and youth policies, like Paul mentioned, but we also need these household level poverty reduction targeting programs, because when we target interventions to improve outcomes that have these multi-level determinants at the individual level, we're really putting the onus on the most vulnerable individuals in society to improve these outcomes, which are actually being simultaneously determined at all of these levels. So I think to the extent that we can reduce poverty at the household level and address these policies in intersectoral ways, I think that's going to be the most successful in improving these outcomes for adolescents. Over.
Thanks very much, Tia. And I think, Rike, did you want to go ahead to the next question as well?
Yes. Thank you. Yes, we have a last question to Kokeka. We'll ask a question to you, but if anyone else has any additional points to make, please go ahead and come in. But you spoke a lot about the importance of involving caregivers in these approaches. Could you speak a little bit about what the role of those caregivers should be, ideally? How do we involve them?
Thank you very much, Rike, for that question. I think caregivers have a responsibility to manage and support, their adolescents. They provide some kind of control and support and build relations in ensuring that the girls are able to grow and become responsible citizens. So in the case of a social policy, I think for me, one example that always comes into my mind when we're talking cash transfers and adolescents, it goes back to the comment that Paul had made to say how much damage are we doing by giving these cash transfers to adolescent girls and young women. In the past couple of years, we were working with the Global Fund, supporting one of the provinces in KwaZulu-Natal in South Africa, where we had a cash plus care kind of intervention, and adolescent girls will then be given a certain amount of cash for attending these interventions that they were attending. It then came back with community engagement with traditional leaders in the area, that we were really interfering with power dynamics of households, because these girls now were coming home with money, their money, not necessarily a household money. So I think as we implement the interventions and as we strengthen social support and social protection for the girls, we need to make sure that we provide support to household, we provide support to caregivers and parents, and not only empower the girls, that may shift some of these power dynamics in households, and also render these girls vulnerable to some of the boys and the men in the vicinity, because now they are known to have money. So I think for me, that's one area that as we implement and design programs, we need to make sure that there's a certain component of strengthening parenting and caregiving, so that they can be able to support and provide that kind of interventions. And I mean, we talk about parenting and caregiving in the role of ensuring that our interventions can provide some parenting skills training, which is what some of the partners working with the Department of Social Development in South Africa are doing, providing parenting skills for fathers, providing parenting skills for mothers, as well as caregivers in areas where we have some of the grandmothers and grandfathers from the older generation having to take care of the grandchildren, where the parents are no longer available, or the parents are either dead or the parents have traveled to work in the other area. So notwithstanding the barriers to parental involvement, I think parents are busy, they work, they leave home early in the morning, they come back in the evening. So, but we have to make sure that as we provide social protection for our adolescent girls and young women, and we empower them to be able to tackle life, but we also strengthen the environments where they are coming from to make sure that we take them out of the poverty cycle and they become responsible as citizens. Thanks, Rike.
Thanks so much. Very, very good reflections. Are there any of the other panelists that would like to chip in on this?
Yeah, sorry, I would like to chip in a bit on this one, especially related to the cash transfers and what is given to adolescents versus their families. Evidence actually points to girls being vulnerable because of a few basic things that parents would actually struggle to provide. So clearly, adolescents really having access to some cash, it's really important. But as you're giving some cash to adolescents, clearly you're also supporting the structure and the context where they're coming from, which are actually caregivers or their families. But clearly they need some access. We have evidence that points to them really struggling on basic things, and that adolescents that are entering puberty, they need to have access to a few things that sometimes families don't provide or parents don't provide. But also when we look at the cash, how much cash are we talking about that these cash transfers provide? It's usually actually very basic. And the assumption is that these adolescent girl who gets maybe just a few dollars in 3 months or 1 month or whatever period of time, that's enough actually to prevent them from entering into risky sexual behavior. And usually that might not be the case. And that's why we see some cash transfers, even the ones that just tackle adolescents, struggling because the cash is too little. And I say it's too little because the assumption is that they're too poor, and hence just a little amount of money should do something. So really proper research, maybe more research, just to understand how much cash is even enough to really get these families and the adolescents themselves off the ground. It could just be too little. We observed some of this in the DREAMS cash transfer programs here in Tanzania. The cash was too little to make an impact in the life of an adolescent girl who was out of school and who was getting much more from the males than the program itself. So clearly, as we're talking about cash, we really have to be reflecting what type of cash, what amounts are these? These are usually very, very little that are given to these families, that are given to these adolescents. It's something, but it might not be enough to make an impact in terms of their economic situations. So I just thought I should reflect a bit on that. But just going back to the caregivers and the parents, very, very important for parenting of adolescents and children in general. That's why social norms are made. When we start talking about social norms at a particular level, tackling the girls directly, the boys directly, that's where it starts at the family level. So clearly, apart from the economic aspects, you also think about the gender norms, the socialization, the impact parents have in terms of how they socialize girls into sexuality, into relationships. It's really key. That's why I think that caregivers and parenting is a key aspect of adolescent sexual reproductive health and general life outcomes. So just those.
Thank you for these reflections, Joyce, and good point also about the amount of the cash. I know there are some papers that have looked at that and looked at a minimum threshold for what is actually impactful. So on that note, there's a question in the chat box on the package of care for caregivers. Asiko Keka is typing an answer, but if any of the other panelists have any documents that are relevant, please do type them in the chat box. Apart from that, we are out of time and we'll have to conclude the Q&A. But if there are any other questions, please send me an email and we will get back to you after the webinar. And then I just want to say a warm thanks again to all of our speakers, all of our panelists for the contributions to this important topic, for sharing their knowledge and insights with us today. It's been really insightful, and we'll try to hold together a bit of a summary of all the recommendations and reflections that we got out of this. In addition to that, we'll post the PowerPoint and recording of the webinar on childrenaids.org within the next couple of days, and all of those that registered will receive an email with those resources and the link. And just another note to say, you can find many more resources related to multisectoral programming for adolescent girls and young women at our website. We have a new revamped AGYW Learning Collaborative, which is also available on childrenaids.org. So please do check that out as well. Thanks again for joining us, all of you. It has been really interesting, and we were happy to see you online.
Thank you.
Thanks very much, everyone.
Thanks.
Thank
Thank you.
Thank
Bye.
you.
everyone.
Bye-bye.